Hello, my name is Fabian Proft, and I'm really excited to have the chance today to speak with my friend and mentor, Professor Denis Poddubnyy, on the long-term data of the gastric cohort. Denis, it is a real pleasure to have you, and I'm really appreciate that you took the time in these busy days to speak with us. Welcome.
Thank you very much for inviting me.
Denis, you are presenting the 10-year data, clinical data from the gastric cohort. Maybe you could give us a quick overview about the design and especially the inclusion criteria of this cohort, and maybe give us a little insight what makes this cohort so special.
Yeah, thank you. Indeed, gastric is still a quite unique cohort. It has been initiated 20 years ago by Martin Rudwaleit and Johann Sieper as a cohort for patients at very early disease stage. Those days we had only a term spondyloarthropathy or spondyloarthritis. There were no clear classification, non-radiographic. So patients with ankylosing spondylitis with symptom duration up to 10 years and patients with axial SBA but without radiographic sacroiliitis with symptom duration up to 5 years were included in this cohort and were followed up prospectively. As a result, we have quite early cohort of patients with symptom duration of less than 5 years overall, and the mean age of this population is also quite young. Patients are clearly at the beginning of the cohort they were below 40.
Yeah, okay. And you are presenting the 10-year clinical data. What are the main results that you are presenting here at this year's EULAR?
There are several interesting observations out of this cohort. First of all, it was quite important in the light of the ongoing discussion whether non-radiographic and radiographic spondyloarthritis are two stages of undiseased. It was important to show that we are dealing with the same outcome both at the beginning of the journey but also over time. And indeed, if you look into the proportion of patients achieving low disease activity state or remission, you can see that it is very comparable across both subgroups. What we do not see clearly, we do not see an excessive rate of spontaneous remissions within non-radiographic axial spondyloarthritis. On contrary, we see that patients with ankylosing spondylitis, radiographic axial SBA, at many time points they had higher proportion of patients with low disease activity or remission that was most likely related to the treatment.
And how, just out of interest, how did they both subgroups differ in the beginning in terms of gender and disease activity, maybe?
Right. This is a very important point. If you look into baseline patient characteristics, you see that patients with non-radiographic axial spondyloarthritis, they more frequently females, they have a bit lower CRP, and proportion of patients with elevated CRP is also lower with the non-radiographic axial spondyloarthritis group. That is most likely related to the fact that they do not have radiographic sacroiliitis, because both factors I mentioned are predictors of progression of structural damage. But at the same time, if you compare non-radiographic with radiographic axial SBA in gastric cohort, you see that the burden of disease, level of pain, stiffness, disease activity are very comparable between these two subgroups, meaning that there is a big need for treatment also at non-radiographic stage.
And what is, from my side, really interesting about gastric is that we consider that this cohort has started almost 20 years ago in an era where we didn't have the treatment options that we're having today.
That's right. This is a correct observation. At the very beginning, we had almost no patients on biologics, on TNF-alpha blockers, and over time, the proportion of patients on biologics has increased. We see that at the end, about 30% of patients in the radiographic subgroup and about 15% of patients in non-radiographic subgroup received biologics in the majority of cases was TNF alpha blocker.
Okay, and you said that also most of the cases TNF inhibitors. What were the other biological demands when going back in time? I'm thinking B cell depleting, or what was it?
Yeah,
Just out of
so
interest.
there were few patients where different treatment modalities were tried, abatacept, rituximab, also as a part of clinical study, but as you know, nothing of that really get into approval or advanced clinical stage. And also in the last years, we got a couple of patients who were put on IL-17 inhibitors once they were approved. What we also clearly see that the treatment pattern has changed over last 20 years. At the beginning of the cohort, we had majority of patients on NSAIDs. Many of them were also treated with steroids, with conventional synthetic DMARDs. For steroids and conventional synthetic DMARDs, we saw over time a clear decline. That makes sense because normally they are not very effective on the long run in patients with axial SPA.
And did the treatment in your cohort differ between the two subgroups, so that the radiographic patients were treated more intensely, or can you say something about that?
Yeah, we see clearly a difference in the proportion of patients who received TNF alpha inhibitors that is related to the approval status in Germany, in Europe, but also in the United States. So the first TNF alpha blockers were approved for radiographic axial SPA, and non-radiographic axial SPA indication came much later, and this is most likely explanation why we see a lower proportion of patients treated with this drug class with a non-radiographic group.
Okay, thank you. And we already spoke about treatment, and that this cohort was going over about almost 20 years. And what is really interesting for me is on such a long-term trial, how about the retention rate? How many patients stayed on the trial? As everybody is aware that being in such a clinical trial for such a long-term run is also challenging for patients and physicians.
Yeah, that's right. We always face big dropout rate in long term, especially observational clinical trials, and gastric cohort was not an exception. With every visit, we lost patients. At the very end, we had only 25% of the initial number of patients who started this cohort, and it is always a question whether or not the dropout rate and patients who dropped out would have changed the study results. It could have been a case if these patients were patients with higher or lower disease activity. We performed a sensitivity analysis. We compared patients who dropped out with patients who remained in the study. And what we saw in terms of disease activity, at least at baseline, there were no major differences between two groups, neither in BASTA nor in the level of C-reactive protein. What was different was age, so patients who dropped out were younger, and also gender. More male patients dropped out from the gastric cohort as compared to females. So I think that in the majority of cases, social factor, mobility of this younger patient population was a leading reason for dropout, and not really a medical reason.
Great. So when you would like to summarize the main outcomes of the presented data, could you share your 2 or 3 key messages with us in the audience?
Thank you very much. So first of all, I do think that this is another piece of evidence that talking about non-radiographic and radiographic axial spondyloarthritis, we are talking about one disease, axial SPA. And I do hope that this message will will be adapted also in the future clinical trials, also interventional clinical trials, where we will get a patient population consisting of patients with axial SPA, not artificially divided into non-radiographic and radiographic groups. And the second point is, it's quite important that despite all the available treatment options, we see at the very end, at year 10, only about 30% of patients were really in remission, meaning that disease control was not possible in full in almost 70% of patients, indicating that there is an unmet need in terms of patient care, but also maybe in terms of new treatment options. And this is something we should take seriously to look for optimized, for better treatment strategies for our patients.
Thank you, Denis. This is a perfect closing remark, as we are having here at this year's EULAR. We have presented the study which closed the gap and also made another therapeutic option with IL-17 inhibitors available for patients with non-radiographic axial SpA. And we are getting more insights in other new treatment options to treat our patients better in the future. So thank you, Denis, for having the time, sharing the results, and giving us so much details on your study. And yeah, I really appreciate it. Thank you.